So now the strabismus. What do you mean by strabismus? What is the classification of strabismus? Normally, the visual axis of the two eyes are parallel to each other in the primary position of gaze, and this alignment is maintained in all the positions of gaze. A misalignment of the visual axis of the two eyes is known as squint or strabismus. Broadly, it is classified as an apparent squint. Squint nahi hai, but it appears like a squint. That is a pseudo strabismus. A latent squint, which is the heterophorias. The manifest squint, that is the heterotropias. Heterotropias are then again of two types, the concomitant squint and incomitant squint. So the squint, apparent, latent, manifest. Manifest is comitant. Incomitant will be paralytic and restricted. So what is phorias? It is a latent visual axis deviation held in check by fusion. Tropias are manifest, मतलब दिख रहा है कि deviation है obvious, and intermittent tropias is an intermittent visual axis deviation which exists only occasionally. Now, pseudo strabismus, that is an apparent squint, visual axes are parallel, but eyes seem like they are having a squint. A pseudo ESO or an apparent convergent squint may be associated with prominent epicanthal folds. यहाँ पे epicanthal folds है, nose bridge broad है, तो ऐसे लगता है कि the patient is having convergent squint, but the visual axes are parallel. Prominent epicanthal fold, which cover the normally visible nasal aspect of the globe and give a false impression of esotropia. Hyperteliorism. It is a condition in which there is wide separation. Wide IPD hai, eyes widely placed hai, but unki visual axis parallel hai. This is a pseudostrabismus because of the flat nasal bridge, wide epicanthal folds, and a small IPD. Prominent epicanthal fold giving an impression of a convergence. Wide IPD giving an simulating a exotropia. ऐसा लग रहा है कि divergent squint है, but eyes are widely placed, but the visual axes are parallel. Now, come to latent squint or heterophoria. Heterophoria or latent squint is a condition in which the tendency of the eyes to deviate is kept by the fusion. Fusion से वो patient eyes को straight कर लेता है, but eyes को straight करने में patient को बहुत energy लगती है, so usually the patient will come to you with pain in the eyes or headache. Therefore, when the influence of fusion is removed by cover test or cover uncover test or cover prism test, तो जब हम एक आंख को बंद करते हैं, तो you will find that the eye under cover deviates. So when both the eyes are open, there is no squint. So this is a latent squint. What is orthophoria? It is a condition of perfect alignment of two eyes, which is maintained even after removing the influence. That is, we are normal, we are not having any phoria or any tropia. So even if you close one eye, you close the other eye, you do cover and cover test, eyes are not going to deviate. So this is the normal person or orthophoric person. Heterophoric person may, when you close one of the eye, the other eye is going to deviate. So what are the types of heterophoria? Iso, जब medial होता है तो हम iso बोलते हैं, जब laterally होता है तो हम exo बोलते हैं. So what is an isophoria? Which is a latent convergent squint. Isophoria or a latent convergent squint is a tendency of the eyeball to deviate inward. अब convergence है, eye converge कर रही है, तो किस तरह से हो सकता है? Latent convergent squint can be an convergence excess type. That means ISO जब patient पास में देखेगा तो ज़्यादा होगा. Convergence excess type. So there ISO will be more for near than for distance. Divergence weakness type. Then ISO will be more for distance than for near. Non-specific type. चाहे near दिख रहा है, चाहे पास दिख रहा है, degree of the phoria is not valid. Now exo. Exo is a latent divergent squint. This refers to the tendency of the eyeball to deviate outward. अब डाइवर्जेंट है तो किस तरह से होगा, कन्वर्जेंस वीकनेस के कारण होगा, सो एक्सो विल बी मोर फॉर नियर. डाइवर्जेंस एक्सेस के कारण होगा तो द एक्सो विल बी मोर when person sees for distance, and non-specific in which the exo does not vary very significantly in degree of any distance. Esophoria, exophoria. Hyperphoria is a tendency of the eyeball to deviate upwards. Hypophoria will be the tendency of the eyeball to deviate down. Cyclophoria will be the torsional deviation, the tendency of the eyeball to rotate around the anteroposterior axis. And if the 12 o'clock position of the meridian of the cornea rotates inward, you will call it as encyclophoria. And when the 12 o'clock of the eye of the cornea rotates outwards, this will be known as excyclophoria. So depending upon the symptoms, heterophoria can be divided into compensated or decompensated. A compensated heterophoria is associated with no subjective symptoms. Compensation of heterophoria will depend upon the reserved neuromuscular power to overcome the muscular imbalance and the individual's desire to maintain the binocular vision. मतलब अगर neuromuscular power बहुत अच्छा है उस person में, so in spite of applying more of the fusion, the patient is not having any symptoms. कोई headache नहीं है, pain in the eyes नहीं है, so that is known as a compensated heterophoria. जो decompensated heterophorias होंगे, there you will get symptoms of muscular fatigue, which will result due to continuous use of the reserved neuromuscular power, and these symptoms will be headache and eye ache after prolonged use of the eye, which will be relieved when the eyes are closed. Symptoms of failure to maintain the binocular single vision, there will be blurring, crowding of the words on reading, and intermittent diplopia. Symptoms of defective postural sensation, like problems in judging the distance and position, especially of the moving objects. This difficulty may be experienced by cricketers, tennis players, and pilots while landing. Now, examination of a case of heterophoria. For any case of heterophoria, first and foremost will be testing for the vision and refractive error. Testing for vision and refractive error is most important because the refractive error may be responsible for the symptoms of the patient or for the deviation itself. Preferably, refraction should be performed under full cycloplegia, especially in children. First is you will do refraction, preferably under full cycloplegia. Second, you will do a cover-uncover test. Cover and uncover test will tell the presence of heterophoria and the type of heterophoria. Iso hai, exo hai, hyper hai, hypo ya encyclos hai. So to perform the cover-uncover test, one eye is covered with an occluder and the other is made to fix the eye. In the presence of heterophoria, the eye under cover will deviate. जैसे अपन cover remove करेंगे तो the eye under cover will deviate. After a few seconds, the cover is quickly removed and the movement of the eye is observed. The direction of the movement of the eyeball tells the type of heterophoria. For example, if the eye moves outwards in the presence of esophoria and the kiss speed se tell you the type of heterophoria. Now, measurement of the heterophoria. The heterophoria should be measured for distance as well as for the near. The patient should be asked to fixate a distant target and should not accommodate with full optical correction. For near, it should be measured at a distance of 33 centimeters using accommodative targets. Commonly used objective test is prism and cover test. Other tests are Maddox rod, that is for distance, Maddox wing, and a double prism test. Prism cover test. The prism and cover test, the prism bar cover test, prisms of increasing strength are with the apex. This is very important. You will place prisms of increasing strength in front of the deviating eye with the apex of the prism in the direction of deviation. The apex towards the direction of deviation are placed in front of one eye and the patient is asked to fixate an object with the other. Then cover and cover test is performed until there is no movement of the eye. This will tell the amount of deviation in prism diameters. This prism cover test is used for both the phorias as well as for heterotropia. You're covering one eye and you're placing the prism in front, and you're placing the prism, this is the normal eye is covered, and you're placing the prism in front of the deviated eye, and you do the cover and cover test. You find the movement of the eye and you stop when the eye shows no movement. That will be the amount of deviation in prism diopters. Second is the Maddox rod test. The patient is asked to fix on a point light in the center of the Maddox tangent scale at the distance of 6 meters. A Maddox rod, which consists of many glass rods of red color set together in a metallic disc, is then placed in front of one eye with the axis of the rod parallel to the axis of deviation. The Maddox rod converts a point source of light, point into a light. See, this is a Maddox rod, and this has got many glass rods. And if you place the Maddox rod vertically, see, one eye the patient will see a light source, which is a bulb, and the other eye say it is seeing a Maddox rod converts the point source of light into a line. So इस आंख से उसको bulb दिखता है, इस आंख से उसको line दिखता है. So you dissociate the fusion, right? You're presenting dissimilar images to the other eye. So the phoreas get detected. और अगर आपने Maddox rod को vertically रखा है, it forms an horizontal line, and if you keep the Maddox rod horizontally, it will form a vertical line. The patient will see a point light with one eye and the red line with the other. Due to dissimilar images to the two eyes, the fusion is broken and heterophoria becomes manifest. This is a tangent scale on which we will test. 6 meter distance पे होगा. Patient को जो trial frame में patient को Maddox rod एक आंख में और एक आंख से वो bulb दिखेगा. कितना deviation है, that will be tested on this Maddox tangent scale. The number on the Maddox scale with the red line falls will be the amount of heterophoria in degrees. In the absence of Maddox tangent scale, the dissociation between the point light and the red line is measured by the superimposition of the two images by means of the prism placed in front of one eye at apex towards the forehead. So this is the right eye. You're testing it for the left eye. If you're keeping the Maddox rod vertically, this horizontally, it forms vertical line. This is an orthophoric patient. Bulb or line एक ही line में है. When there's an ESO, it will be deviated medially, and this is how it will be for exo. Similarly, when you keep the Maddox rod की जो glass rods है, you're keeping it vertically. This forms an horizontal line. So when orthophoria, line and bulb will be in the same line. For hypo, the line will be above, and for hyper, it will be below. This is how you will test for phorias. So this is the Maddox wing. This is the partition which dissociates the image. So one eye is able to see only the letters, and the right eye sees only the red and the white arrows. The patient is asked to tell the number on the horizontal line which the vertical white arrow is pointing, and this will give the amount of phoria, and the number on the vertical line at which the red arrow is pointing, this will give the vertical phoria. The cyclophoria is measured by asking the patient to align the red arrow with the horizontal line of numbers. So this is the numbers, and this is the red arrow, and this is the white arrow, which gives the cyclophoria. Measurement of convergence and accommodation. The near point of convergence that can be measured with the help of RAF rule or the Livingstone binocular gauge. The normal near point of convergence is considered to be around 70 millimeters. Near point of accommodation should be measured with the help of, after you measure the near point of convergence, then you measure the NPA. This is also measured with the help of RAF, and the normal NPA varies with the age of the patient, the near point of accommodation. Correction of the treatment for the phorias would be, first is you have to find out what is the refractive error, and that is to be corrected first. Then orthoptic treatments are prescribed to these patients. It is indicated in patients with heterophorias without the refractive error, and those where heterophorias and or symptoms are not corrected by the glasses. Aim of the orthoptic exercise is to improve convergence and optofositating orthoptic exercises. Simple home exercises can also be given, and aim is to improve convergence, insufficiency and the fusional reserve. Orthoptic exercises can be done by sonoptophore. Simple exercises at home with a pen or pencil at the level of the eye. We ask the patient to bring that pen or pencil close to the eye where it sees to, and like this there are some exercises which you can, simple exercises at home also the patient can do. Third is the prescription of prism in glasses. Prescription of prism in glasses may be tried in selected cases of vitrophoria and in certain troublesome cases of ESOs and exos. Prism is prescribed with the apex towards the direction of phoria to correct only half or at the most 2/3 of the heterophoria. Surgical treatment is undertaken with the patients with marked symptoms and if not relieved by other measures. Aim of surgical treatment would be to weaken the strong muscle and to strengthen the weakness. Now, after the phorias, we come to tropias, that is the concomitant squint and incomitant squint. So first we will deal with the concomitant squint. Concomitant squint is the type of manifest squint, that is a tropia, in which the amount of deviation of the squinting eye remains constant in all the directions of gaze and there is no associated limitation of the ocular movement. Etiology is not clearly defined. The causative factors differ in individual cases. The binocular vision and coordination of ocular movements are not present since birth and are acquired in the early childhood. We know the binocular vision starts developing at the age of 3 to 6 months and is completed at 5 to 6 years. There is a motor component, sensory component and the neural or the central component of the binocular single vision. So if there is any obstacle in the development of the binocular single vision, this will lead to a concomitant squint. So what could be the sensory obstacles? These are the factors which hinder the formation of clear image in one eye, leading to a concomitant squint. So these sensory obstacles are refractive errors, prolonged use of incorrect spectacles, anisometropia, corneal opacity, lenticular opacity, any disease in the macula like a central chorioretinitis, optic atrophy, obstruction in the pupillary area because of the congenital ptosis, and motor obstacles. This will include those factors which will hinder the maintenance of the two eyes in a correct positional relationship in the primary gaze and during the different ocular movements. So few of such factors are either congenital abnormalities in the shape and size and abnormalities in the extraocular muscles, that is either faulty insertion or innervation or mild paralysis. The other paralysis hoga, so that will go into a paralytic squint, and abnormal accommodation or convergence or accommodation convergence upon ACA ratio. Then central obstacles, which could be in the form of deficient development of fusion faculty and abnormalities in the cortical control of ocular movements, as would occur in the mental trauma. So these could be the central obstacle, motor and the neural causes or the central causes of the sensory, motor and central causes of concomitant squint. Now, what will be the clinical features of a case of concomitant squint? Characteristic of ocular deviation would be a unilateral or alternate. Unilateral squint ho sakta hai, unilateral convergent, unilateral divergent, or it can be a alternating convergent or a divergent squint. Inward deviation will be known as an esotropia, whereas in latent squint we call it as phorias. So inward deviation will be esotropia, outward deviation exotropia, vertical deviation hyper or hypotropias. In concomitant squint, always the primary deviation of the squinting eye is equal to secondary deviation. What is primary deviation? Is the deviation of the squinting eye when the person is fixing with the normal eye, and secondary deviation is deviation of the normal eye when the person is fixing with the squinting eye. So in a concomitant squint, primary and secondary deviations are equal and ocular deviation is also equal in all the directions of the gaze. Ocular movements are not limited in any direction. Refractive error may or may not be present. Suppression and amblyopia may develop as a secondary adaptation to strabismus. Amblyopia develops in a monocular strabismus only and is responsible for the poor visual acuity. AV patterns may be observed in horizontal strabismus. When AV patterns are associated, the horizontal concomitant strabismus becomes vertical.